Okay, so we know we've got a micro system, we know we're going to plan to change, but you absolutely have to measure what you're doing. Now, there's measurement at different levels, and we're going to go through those today, but generally speaking through this, we want to try to measure, at least in the planning sense, what we're going to do over the year. So if you're picking diabetes, then you want to have a few measures around diabetes, so that at the end of the year you say, this is better, we can see it's better, right? Once you move into the model for improvement, the measurement around that, because you're looking at a small test, that can be quite different, okay? Because you're looking at a small test of the system, and we'll go through that a bit later on. If you don't have data, you're just another person with an opinion. And I guess that's a pretty important fact. I mean, unless you actually come forward with the facts, and this is really important if you're looking to get your team on board, and you're looking for, say, investment from the business, and it's quite probable that you will come up against a situation with quality planning, quality improvement, where you get to the end of where you can go because you'll need capital investment. Right? We've seen this where, certainly through the early stages of the APCC program, where some of the teams were looking at employment of additional practice nurses, allies coming into the general practice. Now, that means space, facilities, and therefore you really need to have that goes back to planning to say, well, what are we going to do? We need more rooms to get these people in to work. And therefore you may have to change buildings or buy a new one or something like that. That's something you're not going to be able to fix in quality improvement. You can just prove that getting a practice nurse on board can be really efficient, it's good for the business, but then let's get to, well, there's nowhere to sit. Then you end up with a problem, you've got to go back to planning. But if you've got data around it, you can work out what your expected additional revenue will be by employing a different person of a different work time. Okay, the 7 steps to measurement, and this is taken from the NHS, where they've looked at it from decide on an aim, choose your measures, and define your measures, collect data, analyse and present the data, review the measures, and then you keep going in a circular basis. This certainly is quite reflective of that higher order measure around your quality plan. Make sure you've got good measures in place, and then you keep monitoring it over time. Where you get into a model for improvement where you may look at some PDSA cycles, each of those cycles might have slightly different measurement because it is very small tests of the system. So data effectively is simply just raw, unorganised elements in a system, in a computer system, or in some sort of collection. By itself, it actually doesn't mean a lot. But when you organise it and you can transform it or represent it visually, then you start to see how powerful it can be. So we certainly have quantitative data, and that's really numbers in some way where you can actually count, and you can represent by graphically by quantitative data, and these are really pretty easy to work with, whereas qualitative data is a little bit harder to work with. It's more descriptive, and a classic would be things like surveys or interviews, and things like that, where you're looking at people's opinions and views or values. But even with this, where often what researchers will do is they'll transform that into some sort of a numerical way of looking at it. 30% of people thought this broadly. So they will get it back into a way that you can actually look at some sort of graphical representation. So data is really important in quality improvement from a learning perspective. It's not about judgment, and I guess this is where you start delivering data. People go, well, hang on a second, what are they going to do with it? And it really is about learning and being curious about the system and understanding it. When we first started to collect data for the Australian Primary Care Collaboratives in 2005, it was heresy. It was the hottest topic on the orientation tool we were doing, because some people just could not grasp that it was reasonable to collect data on a national basis and look at the performance of general practice. And whilst we're looking at it from a quality improvement perspective, it still is looking at the performance. I mean, you're looking at the proportion of people with diabetes coded with a HbA1c that is current. Those sort of things are performance, and people go, hang on a second, I don't want to put my results on the board. It was huge. But as we went past and we got into the waves, well, that view really dropped away, and a lot of people were really quite excited about being able to measure and compare. And nobody wants to be below the bar. So when we would present data at the workshops, and we'd say, look, here's the average of all of the people in the room, and this is your line. If the line was above the bar, people would go, oh dear, we're above the bar. If it's below the bar, people would go, oh dear, we're below the bar. How do we get it above the bar? What's going on here? But that sort of puts a bit of pressure back on people to say, how do we get it up there? What do we do about it? What are the other people doing? And as part of this sort of work, we used to harvest the exemplars, the ones that were doing a very good job, and then promote what they were doing about that and how they got it to there. So other people could learn and replicate it if possible, if not innovate it and get some improvement. But it is absolutely about learning and about improving outcomes and not about judgment. So you all filled in the QI CAP this morning. You'll be glad to know that's not going to be marked and sent back to you. Okay, and the results will not be put up on the board. That's just part of an evaluation, so that when we look at down the track in probably about 3 months' time, we'll look at getting some people to do that again, so we can actually see has this series and working with the PHN made a difference. So it's about that sort of thing. It's not about getting a mark back to you. So you won't get a mark. It absolutely provides motivation, and even within the team, just simply having it on the board. So this is where we're going this year, and we're getting there. It really is a really powerful motivator. But it is central to achieving things in quality improvement. I mean, if you can't actually have a look at your system and how your system's performing and how it changes when you actually try something, well then you can't go anywhere. Certainly it's a common frame of reference. So when you look at any of the nationally consistent measures that are available, but certainly the first introduction now of the PIP-QI measures, so there's 10 of those, and at least with the vendors now, with the business rules building in these specifications, at least there'll be a common frame of reference. Because if everyone's trying to go and count this, in a slightly different ways, and these systems are very complicated, then you never ever get numbers you can compare. Certainly in our experience with some of the measurement systems, so just as an example, we helped develop the NKPIs for the Indigenous National Key Performance Indicators. Do we have any Aboriginal services here today? No? Well, the Aboriginal Community Controlled Services and some others need to report these indicators into the Commonwealth, and there's 24 of these indicators. And we also developed the indicators for the APCC program. So some of those indicators are really very similar. So for example, people living with diabetes that have got a HbA1c current, and current is really 2 times in the last year is what we were looking at with the APCC, and also the NKPIs. But the NKPIs, for example, they actually included the counting of deceased people, whereas the APCC indicators didn't. They both worked on the 3 times in 2 years rule. So, but if you happen to be, had been at the general practice for 3 times in 2 years and were recently deceased, well then the APCC, excluded those from that count, and the NKPIs included it. So there are differences in the way the measures are done, and it makes a difference in the numbers. And that's generally where it is, and at least here we've got a common set. Yes?
We have allied health at our practice, and multiple the patient is diabetic, so they're not going to be coming on as having HbA1c testing because they see a GP elsewhere. Yeah. So that's going to affect our figures.
Yeah, that's right. So that's where, in that situation, what a lot of people do is they're not seen at your service for the purposes of seeing a GP, right? You might register them on your system. So often what people do is actually mark them inactive as soon as they inactivate the record as soon as they leave, so they don't get pulled up in the results. It's like being in a beachside town where you've got a lot of people coming in for visits or stays, but they're not your township, they're not really your population, and there are procedures you can put in place to actually inactivate those or activate them.
But that doesn't help if they can do online booking, because then they can't book in, or if that's you, and then it creates a double account.
And in that situation, if that doesn't work, because there's actually no results even being put forward, say from these indicators anyway, you have to make a decision yourself about that measurement and where you fit. So being below the bar, for example, sometimes is where you will be, because the situation you're in means you're there. But you need to make that judgment.
But
So-
then we would know that maybe if we looked at just our GP stuff, and it might be good, but then when you do it, including the allied health, it doesn't look so good. So at least we can work on our
Absolutely,
part.
yeah. And you can make those judgments. So we saw that with the APCC program where certainly we saw some services with really very, very good results around all of the process measures for, say, chronic disease. They were doing a lot of really good work, but they weren't getting outcomes. The outcomes weren't there. And that outcomes in this situation meaning things like, HbA1c under control. And it's simply the burden of disease. They're just in an area where they could not, it's a very difficult thing to shift. And because of the burden of disease and a lot of other determinants in health, as long as they have their process work up as good as they could get it, well, it's about what they can do. The rest is outside a general practice or an Aboriginal community-controlled health services, possibility of changing. I mean, you can only ever do too much or so much. You can't fix everything.
Colin, would a register work in this instance where you kind of list all the patients in your system who have a diagnosis in the system, create a register?
You'd probably need to, you'll have an electronic register, obviously that's what the information systems are, but what you were saying about being able to identify those that haven't actually seen a GP, right? And then you'd need to deal a bit with the raw data to be able to determine this, but you'd get those that haven't been seen by GP and you'd take them off, theoretically, the register, and you'd say that's our true result because these are the ones we're seeing with clinicians. But that's going to be just a bit of manual work to do that. But certainly, given the PIP-QI measures, I mean, firstly, there's not any data sent through to the Commonwealth anyway. You need to make some decisions around where you sit on that. It's not a judgment coming down from the government or the PHN to say, what are you doing down there? You say, hang on, we've got a pile of allieds here. That's why we're here, but nobody's going to do that. It's about getting whatever percentage you've got to go up. Certainly differences between what we're saying with improvement and things like research. Generally speaking, we're here to, bring new knowledge into play. We're dealing with a few measures and not everything. Often research grabs a lot of data and crunches it because they've got the power to do it. When you're working in your systems, you're looking to just a few things and they give you a really good idea that what you're changing is going the right way. And the duration, sometimes, you look at population health data, we're talking sometimes it's 2 to 3 years, 4 years old that they're referring to. You're dealing with things that are live and dealing with monthly. And you can look at it monthly and look at changes monthly. There's a big difference between some of the data sets. You'll see enshrined through the standards now are lots of things on data, using data within your general practice, quality improvement activities, etc. So certainly anything you're doing here will comply or will help you comply, with the standards. So we have different types of measures. There's process, output, very similar types of measures, and these are around things you're changing to your system. So a process indicator is about something, an activity you'll be doing. So it could be like the proportion of people with CVD that have had their blood pressure taken within the last year. So you can change that pretty quickly because it's about taking blood pressures and recording them properly. Whereas if you're talking about, say, an outcome measure, well, how many of those with CVD have their blood pressure under control? And that will be a lot less, obviously. Balancing indicators, is something where you're looking at taking an indicator from another part of the system, where if you're worried about putting in a change that might impact in another way on your system, you want to get that measured so you can actually look at make sure it doesn't have a perverse impact on another part of your system. We've got an example coming up in hospital too. Okay, so just from this one here, we've got diabetes HbA1c. Anyone have an idea what type of measure that would be? Average HbA1c level for the population of patients with diabetes. Sorry? Yeah, and if you're looking at a measure that's at the average HbA1c for the population, is that an outcome measure, process measure? Sorry?
8.
8? No, that's the result. Yeah, the result, yeah. This is a, sorry? That's an outcome measure, yeah. And this is an outcome measure as well. And people may not know much about this sort of a measure, the number of days of the third available appointment. This is an access measure that was introduced through the APCC, where the way of measuring delays in your appointment system is to say, well, for all of the clinicians you're taking appointments for, you know, count the number of days it is until the third available appointment. And some GPs, you know, booked up for weeks. Some days, but you actually count them and then you average them, you get them back to the delay in your system. So that's an outcome measure for the delay in the system. So these ones here, these are process measures. You know, so the percentage of patients whose HbA1c level was measured in quarter, it actually should be 2 times in the last year, and the average clinicians' available appointments. They're things that you control in your system about activity. See, this one here, this is readmission rates when measuring length of stay. So this is a balancing indicator. As an example, if you're actually looking to bring down your length of stay in a hospital, what you don't want to see is your readmission rates going up. Because if all you're doing is getting them out too soon and they're coming back in, well, that's completely defeating the purpose. So if you are getting them out, you're getting your average length of stay down, and your readmission rates are remaining the same or hopefully getting lower, well, that's even better. So what we're looking for in quality improvement measures, they need to be reliable, valid, but they need to be responsive over time. In some of the indicators or some of the measures you hear people talking about within healthcare, they are population health by nature. It takes years to shift them. You're looking at things in your system that are going to change, and you've got, they're reliable, but they're also sensitive to change over time. And quality improvement measures are sometimes not perfect. Okay, they're not meant to be research rigorous indicators. They're meant to be an indication of the system and not a perfect result. And sometimes the way in which you measure leaves a lot to be desired, but sometimes things are very difficult to measure. Okay, so if we know the purpose of the data and we know the measures to be collected and the frequency, we need to know who's going to collect it and the method collection. Now, often this is going to come out of your clinical systems or come out of CAT4, for example. And there are a lot of measures within CAT4 that are pre-canned that you can work with. There's hundreds there, literally. And in fact, you can then also set measures through filtering to be able to get data out. But these are, if you've got somebody that you've got your regular monthly collection set, and you know somebody's going to be able to go and get the measures and put them into an Excel spreadsheet and graph them, then you've got a good outcome. There are a number of barriers to measurement. Certainly, and this is, I guess, where people say, well, what are you going to do with the data? And this question's come up today for the PHN. What are you going to do with the data? Well, the PHN returns quarterly summaries to you around what's happening within the population and where your performance sits. And certainly now we're moving into more quality improvement activity, then there will be other services the PHN can provide you back because they actually have your data. But if they're not doing anything with it, you'll be saying, well, why do we give it to you? And you say, well, because we have to. And you go, well, that's great, but ideally we'd like some benefit from it. Threatening, I think we're seeing a bit of that too, where people are concerned about the measures being used or the results that are being presented, used in some way that would disadvantage the practices. And certainly that's not proposed at all. Too many measures, I mean, we've got 10 at the moment in the PIP-QI, but in your work, ideally, you'll only need to be looking at 2 or 3. You don't have to focus on any of the 10 PIP-QI measures. You can do something different if you want to. Focus on fewer measures. Automated processes. Provide protected time, because people will need, time to do stuff. And discuss measurement with the team. Certainly if you've got a team that meets regularly, having data for them to actually review in a standard position on the agenda to be able to review that is ideal.